The indirect acting. In the indirect acting, we have, as I told you, the acetylcholine esterase will be inhibited. Now, as it can be reversible and irreversible. What happens is there's an anionic site and then esteric site. So, if you block any one, see, carbamates are reversible. See, carbamates are what we talk about the neostigmine, pyridostigmine, physostigmine. Irreversible are the organophosphorates. So what will carbamates do? They'll attach to the both sides. Okay, they'll attach both sides and of the acetylcholine, and then so esterase will be inhibited. But organophosphorates, they bind only to the esteric side, so you cannot hydrolyze them. So it's an irreversible blocker. Okay, so to yeah, so to break this esteric site, you have to give oximes, because it's a free radical site. Oximes only is the only thing which can break this irreversible blocker. Okay, now first we'll talk about carbamates. Now carbamates, we have as I told you, edrophonium, physostigmine, neostigmine, pyridostigmine. Now edrophonium is used in reduction of myasthenia gravis, and also edrophonium is used in treatment of myasthenia gravis and is also used to differentiate between cholinergic crisis and myasthenia gravis, while pyridostigmine and pyridostigmine, neostigmine, all these things are used in treatment of pyridostigmine, neostigmine, and ambinomium are used in treatment of myasthenia gravis. Okay, so that is about carbamates. Now, what is the difference between physostigmine and neostigmine is that, see, physostigmine is lipid soluble, but neostigmine and pyridostigmine are water soluble. Since it's a physostigmine is a lipid soluble, it can be used as a miotic. It can cross the cornea, but physostigmine and neostigmine are all not water soluble. It cannot cross any blood-brain barriers. It cannot do most of the effects. So it's only used in treatment of myasthenia gravis. It's only used in treatment of myasthenia gravis. And also physostigmine is useful for atropine poisoning. So that is why we give most of these drugs in atropine poisoning. Okay. Now is organophosphorus. We have parathion, malathion, diflos, tabum, sarin, suman, ecothiopate. See, ecothiopate is the only pharmacological drug which is being used, and again it's given for angle closure, the open angle glaucomas. Now, if this OPC poisoning becomes more, OPC poisoning is nothing but cholinergic poisoning. Cholinergic system becomes more, what happens? You'll have more of urination, dumbbells, you'll be more of diarrhea, urination, M for more of meiosis, B for bronchoconstriction, bradycardia, E for emesis, L for lacrimation, S for salivation. So OPC poisoning is the cholinergic system poisoning. Since it has a more of cholinergic system poisoning, we have to give what? We have to give atropine, right? So atropine is given for all these poisoning except for endrin. Endrin will not have an antidote. So so this is what is seen in OPC poisoning. Now, okay, so these are all acting on the okay, so these are all what happens in the these symptoms will happen because of the action on the muscarinic receptors. We will be talking more of muscarinic receptors. We haven't come to the nicotinic side. Now, nicotinic symptoms can also be present. Since it increases ACH, we have both nicotinic symptoms and we have the muscarinic system. For muscarinic symptoms, we can treat them by giving atropine. Nicotinic symptoms, what happens is if the nicotinic group becomes at that is the NM, that is the neuromuscular junction, we'll have more of fasciculations, we'll have paralysis. Now this cannot be treated by giving atropine because atropine is only going to act on muscarinic receptors M1, M2, M3, M4. So there's no point of giving for muscle paralysis, respiratory paralysis. It will not act, atropine will not act here. So that time we have to give oximes, that is the pralidoxime and diacetyl monoxime. So all these oximes are the one which can reverse the muscle paralysis. So this is what is given here. See, in OPC poisoning we can have both muscarinic and nicotinic group. But since atropine, what is atropine? It's a competitive agonist of the ACH at the muscarinic site. So since competitive agonist of ACH at the muscarinic, so all the signs of atropinization, till the signs of atropinization appears. What are the signs of atropinization? See, diarrhea will stop, urination will stop. So, and again, secretions or salivation, lacrimation, everything will stop. They'll have a dry. That's why it's called as dry as a bone. And hyperthermia, because of all these secretions, hyperthermia will be there. Flushing will be there. Blind as a bat. See, it causes meiosis. Meiosis is not going to. Meiosis is what? Constriction of the pupil. If you do mydriasis, you are not going to see anything. So mydriasis and cycloplegia and all these things are signs of atropinization. So reliable sign is drying of the respiratory secretions, mydriasis, tachycardia. Heart rate is less in OPC poisoning. Heart rate, if it becomes more, you can stop slowly. You can stop giving IV atropine here. So these are cholinergic systems, cholinergic drugs, or you can call it as muscarinic drugs, or you can call it as parasympathetic drugs, whatever you want to name it. Yeah, and also one more thing, we finished more of this one. Now for Alzheimer's disease, they are also known as, these are also because of Alzheimer's disease, it happens because of decreased ACH. So if you give centrally anticholinesterase are given, what happens is the ACH amount will be more. So those drugs are donepezil, rivastigmine, galantamine, tacrin. All these things are helpful in reducing the degradation of Alzheimer's disease. So this is what happens in Alzheimer's. Also, we've talked about so that is in all you have to remember is what are the direct acting drugs, what are the indirect acting drugs, and what is the treatment for all the poisonings. So that's it.